welcome to my presentation on the medications competency for the exam. I actually did this presentation already live, but then I realized that I had forgotten to record it. So here I am redoing it in the comfort of my own home. Thank you to the Diabetes Educator section for sponsoring this presentation, as well as AstraZeneca for supporting it as well. So I hope you guys, your studying is going well for the exam. This presentation is more geared towards nurses and dietitians. For pharmacists, this is more of this kind of a review of the medications. So let's get going. These are my disclosures. I've done presentations for a number of pharma companies. And here's the program objectives. I want to discuss why insulin is important. I want to review some of the oral hypoglycemic meds. And this will work through a little bit of the targets and work through some possible test questions as well. So let's go here. So I want to just review normal glucose metabolism, because if you don't understand normal glucose metabolism, you can't understand abnormal glucose metabolism. So I think this is a very important slide. I've shown it on my other presentations as well. And so remember, if you find a pathophysiology question, and there'll be plenty on the exam, try to think back to this diagram, because you can usually work it out if you can remember this diagram. So in diabetes, there's this interplay between insulin and a lot of counter-regulatory hormones. Your brain is using glucose right now as you watch this video, as are your muscles. However, there's lots of storage mechanisms for glucose in your body as well. Your body stores glucose as glycogen mostly, and the liver is a big store of glycogen in the body. It stores about 75 grams of glycogen, and your muscles store between 300 and 500 grams of glycogen as well. So when you're eating, your body produces insulin, and that converts glucose into storage form glycogen, which is stored in your liver and your muscles. And then when you're not eating, your counter-regulatory hormones like glucagon, catecholamines like adrenaline and things like that, they stimulate breakdown of glycogen back into glucose so that you can use the glucose for energy. So why is insulin important? Let's take a look at this. So this is Teddy Ryder, and this is this is a picture of when Dr. Banting, who was a University of Toronto professor, just started experimenting with insulin. So Teddy Ryder has type 1 diabetes, and he was one of Dr. Banting's first patients. And you can see on the left, my left anyway, that was Teddy before he started insulin. And the second image on my right is after he started insulin. So if you take a look at the first picture, you can see that Teddy is really skeletal. Take a look at his chin, his neck, and his legs. They're very, very skinny. And the reason why he's so skinny is that with type 1 diabetes, he can't produce insulin. His immune system, for whatever reason, thinks that his pancreas is a bad guy and has sent immune cells, white blood cells and things like that, to destroy his pancreas. And so without insulin, the food that we eat, it just sticks in the blood and then eventually gets urinated out. None of the nutrients or glucose from the food is being put into the liver or the muscles. And so poor Teddy here, he's literally wasting away. Insulin is a normal part of the blood. Insulin is responsible for taking proteins, carbohydrates, and fats and turning them into more complex molecules. It's an anabolic hormone. And so without insulin, your body can't use those nutrients, and then just tissues start wasting away. So before the invention of insulin, type 1 diabetes was actually a death sentence. And so Teddy was fortunate enough that he saw Dr. Banting and was started on insulin, and that way he could gain weight. So if you look at the second picture, he looks much healthier. He's got he's got weight on him. He doesn't look cachectic, and that's because he will start on insulin. Here's another picture as well. So again, this is Teddy Ryder on before and after insulin, and you can see how skeletal he is without insulin. Your body just can't store and use the glucose that you consume without insulin. Insulin's a normal part of the blood. Okay, and then this is just another example of what is happening. Here's another patient, type 1 diabetes, before and after insulin treatment. Again, on the first picture, she's very skinny, skeletal, and then she's gained a healthy amount of weight on the second one. So this is not a real test question, but I just wanted to show this because I felt it was important. So what was the average expected lifespan of a 10-year-old diagnosed with type 1 diabetes before the advent of insulin? So I'll give you a sec. 1, 2, 3, 4, 5. And the answer is 2.6 years. So if Teddy didn't meet Dr. Banting and didn't get the insulin treatment, he would have probably passed away 2.6 years after that picture. But this is just to illustrate how fatal type 1 diabetes was. Now, the 6.3 years is the average lifespan of a 30-year-old person diagnosed with type 1 diabetes. So even at 30, not that great, 6.3 years. And then the 9.5 years is a person diagnosed at age 50. And the 14.3 years is just something I made up. So just to review, you need insulin for glucose to enter cells, and that's how the cells can have energy, and that's how insulin promotes normal glucose metabolism. Okay, so going back to this diagram, I actually had a patient of this just last month. Now, this case for my patient, he was orphaned at a young age, but it's pretty clear that he looks quite like he has some Native American ancestry. So he's been my patient for a while, and his A1C was uncontrolled. And then it got to about 8.5, and I started him on insulin. And then he was able to get his sugar down. His A1C was down to about 7.5% or so. And so then he got lost to follow-up for a while. And I hadn't seen him for about a year or so. And he had, in the meantime, stopped all of his insulin. I saw him about a month ago, and when he came back, his A1C was 14.4, and he was extremely gaunt. I'd never seen him so gaunt before. He had like no flesh here anymore. He was kind of like a jolly, slightly overweight individual, maybe BMI of like 29-ish to 30-ish, like not morbidly obese, but definitely overweight. And so, yeah, when I saw him, he had stopped his insulin. He had mentioned that his vision was extremely blurry. There was one time he almost blacked out in Tim Hortons. And so I restarted him on insulin right away. And I saw him about a week ago, and he had gained like almost like 15, 20 pounds. It was remarkable in such a short amount of time how much weight he had gained back. But he looks normal now. His weight, like his chin is back. And so, yeah, that was just a real life example of how this works in real life. His pancreas probably wasn't secreting a lot of insulin. And without the insulin, he was just kind of wasting away. He felt weak, he had lost muscle. And now that we have him back on insulin, he's feeling a lot better. So again, this diagram here is just to reinforce that. Your brain takes up glucose, your muscles need glucose, and then insulin will stimulate the body to store that glucose in your liver and in your muscles as glycogen. Okay, so this is Dr. Banting, and this is the letter that Teddy Ryder wrote to Dr. Banting after his insulin treatment. So it says, "Dear Dr. Banting, I wish you could see me now. I am a fat boy now and I feel fine. I can climb a tree. Margaret would love to see you. Lots of love from Teddy Ryder." And so, after insulin, Teddy was able to gain weight, gain muscle strength, climb trees. But as a side effect, there is that side effect of weight gain. Insulin is an anabolic hormone and causes people to gain weight. And here is Teddy Ryder in a ripe old age. So if Dr. Banting wasn't around, he probably would, when without insulin, he probably wouldn't have lived to this age. But here's Teddy Ryder at a ripe old age. So there's about 3 million people in the world right now with type 1 diabetes, half of which are children. Dr. Banting invented insulin therapy, and so insulin is actually a Canadian invention. Without Dr. Banting's invention, those 3 million people would probably pass away. So you know what, in a lot of movies, it always depicts the Americans as saving the world from like aliens or Nazis or computer viruses or whatever. But this is a Canadian invention. And so I think they should, we're Canadians and we're heroes. I feel we're heroes for that too. So I feel the Americans should not always get all the fame for stuff like that. Yeah. Okay. Okay, so I'm going to introduce a couple of other characters into the story. So first is the kidneys. They play a role in reabsorbing glucose from the urine. So initially, sugar is filtered out of the blood and into the urine by the kidneys, but then the kidneys will grab that sugar back and put it back in the blood. So why do you think it does that? Just think about it for 1 sec. So the answer is that the kidneys are urinating. If the kidneys didn't do that, they'd be urinating about 180 grams of glucose per day. So think about that in slices of bread. 15 grams of carbohydrate is a slice of bread. So you're urinating out like 12 slices of bread each day if the kidneys didn't have this mechanism where it grabs sugar back from the urine back into the kidneys. So, even in a first world country like us, we're fortunate and grateful to live in a first world country like Canada. It would actually cost a fair amount of money to have an extra loaf of bread, to have to buy and eat a loaf of bread every day. So imagine if we were in a poorer country, and there's lots of poor countries in the world, or imagine it was back in time and you were a caveman and you urinated out all this extra energy. At the first famine, you would probably be the first person to die because while everyone else is eating like 2 slices of bread, you're eating like 2 slices of bread and a loaf of bread just to survive. So it's probably a mechanism that evolved where we take sugar out of the urine and put it back into the blood to save energy. Let me just see here what else is in my notes. Okay, all right. There's also the intestines, which play a role in secreting incretins. Incretins travel to your pancreas and help you produce more, help stimulate the pancreas to secrete more insulin. And they also do an important job of decreasing glucagon, which is a counter-regulatory hormone. Incretins also travel to the brain to make you feel full. Okay, oops. There's also fat cells. Fat cells play a role in glucose metabolism. They're actually very active, and they are actively secreting hormones. If you have a lot of them, they secrete hormones that are pro-inflammatory and resist insulin. And then there's the brain as well. There's in people with diabetes, there may be this dysfunction where those incretins don't signal satiety as well. So people with diabetes, they already have enough sugar in their blood, but their satiety signals might not be working well, and they're actually eating more food, leading to more hyperglycemia. And of course, at the center of all of this is the pancreas, where without the pancreas, you're not making enough insulin, and that's what leads to diabetes. Remember, the Diabetes Canada guidelines classifies diabetes as either a dysfunction of insulin secretion, a dysfunction of insulin action, or a combination of both. Okay, so here's a summary slide. One of the reps I work with, Gord of AstraZeneca, coined this slide, ominous octopus. So we can see that all these different mechanisms can lead to high blood sugar. Yeah, and there you go. Okay, so it's not, so diabetes affects like everything in the body. It's not just a disease of the pancreas and the pancreas alone. There's lots of systems which are affected by insulin. Okay, so also very important is, of course, healthy eating and physical activity. As per the guidelines, you can see here on the sidebar that healthy behavior interventions are always to be encouraged at every stage of the disease. So, and this diagram in particular is very important. You should memorize it for the exam. Okay, so let's take a look at a sample question. What should the A1C target be for a 19-year-old male with type 2 diabetes with chronic kidney disease, hypertension, and morbid obesity? He hates hypoglycemia and wants to avoid hypoglycemia under all circumstances. He also has a fear of needles. So why don't you take a look at that, and I will be right back in a minute, and we'll just go grab a glass of water. Okay, so the answer is B. So an A1C of 7% is the target for most people. Now, what's the benefit of having a target of 6.5? So people, if you want to aim for a target of 6.5, that has a benefit of reducing the risk of retinopathy. However, it must be balanced against the risk of lows. And so, you know, one of my students remarked, but everybody hates lows. Like, what's, how can we, you know, shouldn't the answer still be A? And for the exam, you'll have to kind of look into the situation. This patient hates lows, yes, but they specifically mention it. And so if they specifically mention something, they're probably trying to push you towards a answer, one of the answers. Like, yes, you could still, in real life, you could still talk to him, convince him that, hey, you know, I know you hate lows, but you're really afraid of retinopathy, so why don't we go for an A1C of 6.5? But for this question, there's something specifically pointing you away from 6.5. So for this question, the answer would be 7%. 7.5 is like for people with disability, and so is 8.5 as well. So for this question, the correct answer is B. Okay, here's another question. So I'll just let you read that quickly. You can pause the video if you want to take a look at it. But the answer for this one is 8. So people, a big part of the 2018 guidelines, a big change, was in the 2013 guidelines, the target was like 7 for everyone. And so something that the 2018 guidelines really emphasized was this kind of individualized target. Sorry, actually, it was the 2008 guidelines where it was like an A1C of 7% for everyone. Even with the 2013 guidelines, they had started to individualize things. But individualizing their targets is an important part of the guidelines and the exam. And so for this person, because she is functionally dependent, she would have an A1C of 7.1 to 8%. If she was frail, it would be 7.1 to 8.5%. B would be for people without frailty, and then A would be not reasonable because, you know, given her age and frailty, we would be more worried about her going low and falling than the risk of retinopathy. So the correct answer for this question is C. And here's one more question. So just pause the video if you want to just read the question and take a look. Okay. Oops. Sorry, I doubled that. So again, the answer is 7. Here we go. Okay, so the answer for this one is 7.5. That's the recommended targets for children. The reason why it's a little bit higher for children is because children are able to vocalize that they're having a low, or they might not understand that they are experiencing a low. You know, a 4-year-old might not understand hypoglycemia. And so that's why there's a higher target for children. Another important point is that children their brains are developing. So they're actively myelinating their nerve cells. Myelination is when you have this fat sheath around nerve cells, and it helps it conduct faster. So to do proper myelination, you need a constant and consistent supply of glucose. And there's some studies that show that severe hypoglycemia as a child may lead to developmental difficulties later on in life. So in this case, because the child is not suffering from hypoglycemia or hypoglycemia unawareness, the target would be 7.5. Okay, so here's the classes of medications for diabetes. Which one of these don't use insulin? So just take a look at those and think about which ones don't involve insulin at all. So the first one is SGLT2 inhibitors, which work exclusively on the kidneys. And then the other one is alpha glucosidase inhibitors. So things like acarbose that work in the gut to decrease carbohydrate absorption. SGLT2 inhibitors like Jardiance and Forxiga and Invokana, they don't actually affect the insulin system. They just affect the glucose going through the kidneys. Okay, so start looking at the treatment for diabetes. Metformin is listed as first-line treatment for diabetes. So why is that so? What benefits does it have over other diabetes medications that make it first line? And so the answer to this one is E. It has a low risk of hypoglycemia, and it has a low risk of weight gain. So let's take a second, because I want you to understand this as much as possible. And so actually, I'll get back to this, but I want you to, we'll go through the slides, and I want you to think back on why this is so. Why does metformin have a low risk of diabetes, and why does it have a low risk of weight gain? So, but before that, let's do one more question. Okay, and you can just pause the video if you want to just look through it and think about it. But the answer for this one is A. So there will be a lot of not questions on the exam. So which of the following patients would not be inappropriate? So really, it's asking what is an appropriate patient for this exam. Unfortunately, there'll be a lot of these not questions. And so what I do when I write the exams, and what I encourage my students to do, is actually circle the not in the questions. That way you won't be tricked, because I'll be honest, I've been tricked by these questions before, and I always kick myself saying, oh, of course, I knew that, but I didn't look at the not. So metformin is contraindicated for people with type 1 diabetes. Metformin does require, for some of its effects, requires insulin. And so with type 1 diabetes, there is no insulin secretion, and so it's contraindicated for that. Metformin does work on the liver, and in people with severe alcoholism, liver cirrhosis, and things like that, it's also contraindicated. And under severe dehydration, if a patient is throwing up, is sick, a sad man's, and they're severely dehydrated, then this is also contraindicated. So what is the risk of severe dehydration in metformin? The risk is actually lactic acidosis. Lactic acidosis is this very rare side effect that metformin is thought to cause. And that's when lactic acid builds up and the body is too acidic, and it is a dangerous condition if it occurs. For the exam, definitely you can say that, if it has a question of metformin lactic acidosis, then that is a possible answer. But in real life, it's actually quite rare. And there's some studies that show that metformin may not be really linked to lactic acidosis. It might be that just diabetes in general causes lactic acidosis. But for the exam, metformin does have a risk of lactic acidosis. Okay. Sorry, I must have doubled this slide. Okay, so let's look at biguanides, which is the class that metformin is. So what it does is that it enhances insulin sensitivity in liver and peripheral tissues. Basically, it improves insulin resistance. And it works on the liver to tell the liver to stop breaking down so much glycogen back into glucose. Because the liver is very sensitive to insulin signals. If there's lots of insulin, then the liver will start taking all the sugar in your blood and turning it into glycogen. If there's not enough insulin signal, then the liver will think, oh, okay, then I guess we need sugar. And so it starts breaking down glycogen into glucose. As we know, with beta cell dysfunction, there's less and less insulin production with type 2 diabetes. And so if that liver doesn't get enough of that insulin signal, it just automatically assumes that there's too little sugar in the blood and starts breaking down glycogen back into glucose. Okay. It's originally linked to a French lilac flower. So its most common side effect is GI issues. So how can you help patients with this? There's a couple of options. One is to start low and go slow. So typically I start my patients on half a tablet twice a day. You can also even start half a tablet once a day if they're really sensitive. But the most important part is to start to dose slow, and I typically increase the metformin by half a tablet every week or so. Another thing you can do to help patients is to advise to take it with food. That seems to decrease the stomach side effects. Another thing you can do is to look at Glumetza, which is an extended release version of metformin. That seems to help people tolerate the GI side effects as well, but it's typically not covered by provincial, well, in Alberta, it's not covered by the provincial plan and the seniors plan. So you would have to look into their drug coverage and see if that is covered. Oops. Okay, the risk of hypoglycemia. So why is the risk of hypoglycemia low for metformin? And that's because metformin, it doesn't directly stimulate insulin. And because it doesn't directly stimulate insulin, it has a low risk of causing low blood sugars. And similarly, with weight gain, metformin is weight neutral. And that's because, again, metformin doesn't directly stimulate insulin secretion. And so metformin is neutral in weight gain. Actually, a lot of patients will actually lose a little bit of weight on metformin, but it's not strong enough that it falls into the same category as SGLT2 inhibitors and GLP analogs. Okay, so cardiovascular studies. So if you look at the UK PDS, in a subsection of people with diabetes, of the patients in that trial, obese people seem to have a reduction in myocardial infarction in overweight individuals. However, that study it took a long time for that for those results to appear. The UK-PDS and the follow-up study for looking at the legacy effect, that was 10 and 20-year studies. That's a long time to have to wait before cardiovascular outcomes show up. That's in direct contrast to SGLT2 inhibitors and GLP analogs. Those studies have found, certain medications have found that a very quick reduction in cardiovascular outcomes. But still, metformin does have a small effect. And other considerations, that was for any other, that was more for my students live, if they had any other questions on that. Oh, and there, you do have to remember that metformin is renally dosed, and needs to renally dosed, and there's a rare side effect of B12 deficiency. So metformin comes in various formulations, and it comes in tons of combinations of DPP4 inhibitors and SGLT2 inhibitors. So for this next question, I actually made a bit of an error. So it's metformin 2 tablets twice daily, and Onglyza 5 milligrams in the morning. So it's metformin 500 milligram 2 tablets twice daily. Yeah. And so this is a sample question that showed up in one of my exams, actually. So the answer for this one is D. You would just take the 1,000 times 2, that's 1,000, and then the 2.5 milligrams, two of them to equal the 5 of the Onglyza 5. So looking at second-line medications will be a big part of the exam. You kind of have to approach it as if you were the prescriber, or the doctor is going to follow whatever recommendation that you give. And so there's a lot of factors to think about when recommending or prescribing a medication. You need to look at the individual patient characteristics. You need to know about the renal function cutoffs. If they have clinical cardiovascular disease, then they would favor a GLP analog or SGLT2 inhibitor with CV benefit. There's patient preferences. If a patient doesn't like needles, you're going to have to, try to convince them and review the benefits. For needles, I found that the best way of reducing a patient's fear is just to actually show them the pen and do a dry injection on yourself. A lot of patients, when they think of injections, and especially insulin injections, they'll think about their grandmother who boiled this gigantic insulin syringe and gave herself insulin, and after she started insulin, she passed away shortly after. So that's the imagery that patients have in their head when you tell them that, oh, maybe you need insulin. And so you really need to dispel that effect. And so I bring out the pen, I show them the needle, they look at the needle and say, oh, and I mentioned that, this needle is not much bigger than one you poke your finger with. I do a dry injection on myself, it doesn't hurt, and then the patients can see that it doesn't hurt. I'm talking to them while I'm explaining this. And so that really puts their mind at ease. And that's something that we should be doing as well. We should be trying to help the patient be as comfortable as possible. So yeah, there's lots of patient preferences to consider, things like weight gain, fewest number of pills, injections. Another thing on the exam will be contraindications to drugs. So for example, the medullary thyroid cancer with GLP analogs, the bladder cancer, contraindication in certain medications, the glucose lowering efficacy. If their A1C is 14, then acarbose probably isn't going to bring them to target. Risk of hypoglycemia is important. If I have a elderly, frail person, I'm less likely to use medications that can cause hypoglycemia. Affordability is probably the biggest one. So you need to know what's covered by the provincial formulary and see what's on their plan. Sometimes I've just phoned, usually patients have their insurance card with them. I'll just phone the plan right there with them in the office, and see what's covered. And then effect on body weight is important too. Nobody wants to really be on medications that cause weight gain. Okay, so let's talk about SGLT2 inhibitors first. And here's just a question to prime that pump. Oops. Okay. So the answer is C. So there's two SGLT2 receptors in the body. Most of them are in the kidney. SGLT2 and SGLT1 primarily work in the kidneys. And SGLT2s work at higher blood glucose concentrations, and SGLT2s work when the blood sugar is low. So this is the reason why SGLT2 inhibitors have a low risk of hypoglycemia. If you inhibit the SGLT2, that's fine. They don't work when the sugars are high, but when the sugars are low, SGLT2 inhibitors don't work on the SGLT2 ones as much. And so if your sugars are low, the SGLT2 ones work, and they start bringing sugar from the urine back into the blood, and that stabilizes a person's blood sugar. So if you I want you guys to understand how these medications work so that you have a minimum amount of memorization to do, because you've got a lot of stuff to memorize for the exam, and so I just want to minimize as much as possible. Yeah, so A is incorrect because SGLT2 1s and 2s are both found in kidneys. SGLT2s work at sugars above 4 when sugars are high. C is correct. And SGLT2s are, again, they're both found in the kidney. So C is the correct answer. And so let's take a look at how they work. And so here's the kidneys. There's the glomerulus and the tubules. And as it filters out the blood, sugar is filtered into the proximal tubules. There, SGLT2s absorb 90% of the sugar and put it back in their blood, whereas SGLT2s, when sugar is low, they put about 10% of the sugar back into the blood. And so here's an animation, and you can see that here's these purple things, which are the SGLT2 receptors, that take sugar, the receptors and transporters, taking sugar from the filtrate and putting it back in their blood, and dapagliflozin blocks that so that more sugar gets into the rest of the kidneys and less back into the blood, and eventually it's excreted. So you increase urinary excretion of excess glucose, about 70 grams of glucose per day, which is equivalent to roughly 5 slices of bread. This slide shows that patients on Forxiga saw significant reductions in A1C when added on to metformin. So the purple is dapagliflozin, and the gray for the first one is placebo. Then for the second column, it's metformin alone, and the purple is dapagliflozin with metformin. And as an add-on, the gray is the placebo, and the purple is the dapagliflozin. In addition to A1C reductions, patients also saw reductions in weight and blood pressure. So the weight I've talked about is because as you're urinating out glucose, you're also urinating out calories, so that leads to a bit of a calorie deficit. But why the blood pressure? So think about it this way. We put people on thiazide diuretics like hydrochlorothiazide and indapamide to lower their blood pressure. It works as an osmotic diuretic and gets rid of excess fluid. The SGLT2 inhibitors also kind of work in this way. They work kind of as a diuretic, and then that lowers blood pressure slightly as well. So that is something to keep in mind when prescribing or recommending it. If a person's blood pressure is already super, super low, then putting on an SGLT2 inhibitor may cause additional dizziness and lightheadedness. If their blood pressure is really low, then you might want to consider reducing their blood pressure medication when starting someone on an SGLT2 inhibitor. Okay, and this is just a slide showing that weight values remain below their initial measurements even after several weeks and years. Okay, so SGLT2 inhibitors, let's just review this. They inhibit the SGLT2 transport protein to prevent glucose reabsorption from the kidney. Side effects, so try to understand them, that way you don't have to memorize them. If you've got a lot of sugar in the urine all of a sudden, what loves sugar? Yeast and bacteria. And so that can increase their risk of having a UTI or a genital myocardic infection. It can also cause hypotension because, as I discussed, it acts as a little bit of a diuretic. And so that can reduce the blood pressure, and it's a risk for people who are elderly. And that's also why it's contraindicated under a certain GFR, because if your kidneys aren't filtering any sugar anyway, then inhibiting the sugar from coming back. Okay, how do I explain this? So if your kidneys aren't working well anyway, you're not filtering anything. And so if you have nothing to filter and you're grabbing back that sugar, which is not filtering much anyway, you're not having much of an effect. And so that's why SGLT2s don't have a lot of glycemic lowering if their kidney function is low. There are also rare cases of diabetic ketoacidosis. So what is diabetic ketoacidosis? So diabetes ketoacidosis is when your body starts turning too much fat into ketones, and unfortunately ketones are acidic, and it can make your blood too acidic, which is then a medical emergency. So DKA is usually associated with high sugars because you have this deficit of insulin, and the deficit of insulin stimulates the body to burn fat into ketones. So your brain's preferred source of energy is glucose. However, if there's not enough insulin, your body still needs to have energy to run the body. So the alternate source of energy for DKA is ketones. And so your body will start burning fat into ketones to use as an alternate energy source for your brain. The problem is that if you have too much ketones, it makes your blood too acidic, and then that leads to problems. So a phenomenon that has happened with SGLT2 inhibitors is that you can get what's called euglycemic DKA, in which the sugars aren't really that elevated, but they're still in a condition of diabetic ketoacidosis. And so there's still lots of different theories on why that's happening. My two cents is, okay, you need insulin and you have glucagon. If you have too much glucagon and not enough insulin, then you're in an insulin deficient state. And an insulin deficient state doesn't allow glucose to get into the cells, then your brain needs energy, and then your body starts shifting into ketones, starts shifting fat to burn into ketones. SGLT2 inhibitors actually cause a bit of a increase in glucagon. And without high sugars stimulate insulin production. And because SGLT2 inhibitors reduce sugar, that leads to less insulin secretion. But SGLT2 inhibitors also increase glucagon production. And so this causes an insulin deficient state. And that is a possibility of how SGLT2 inhibitors cause DKA, euglycemic DKA. For the exam, what you just really need to know is that SGLT2 inhibitors can cause this euglycemic DKA. Okay. So just for further review, SGLT2 inhibitors, risk of hypoglycemia, it's low because the SGLT2-1 kicks in to grab sugar from the kidneys back into the blood when sugars are low. So the risk of hypoglycemia is negligible. And let's look at weight gain. Usually SGLT2 inhibitors promote weight loss, losses of 2 to 3 kilograms. There is a reduction in MACE. So MACE is myocardial infarction. MACE is an acronym for cardiovascular outcomes. And so empagliflozin and canagliflozin have shown a reduction in CV death in participants with clinical CVD. Okay. So another sample question, and then I think I'll just end today's presentation at the end of SGLT2s. So which of the following conditions is the least likely to predispose someone to diabetic ketoacidosis? So just take a look at that one. So the answer for this one is hypoglycemia. So dehydration is part of that. For SAD mans, if your patient is sick and dehydrated, they want you not to take SGLT2s. So dehydration is a risk of SGLT2s causing diabetic ketoacidosis. So that's definitely would contribute. A keto diet would contribute because you're actively not eating carbs and trying to produce ketones. Sickness is condition which can cause dehydration, and that can predispose someone on SGLT2 inhibitors to have diabetic ketoacidosis. So the only one here is hypoglycemia, and which is the correct answer. Which of the following SGLT2 inhibitors has a black box warning? You can pause the video if you want, but the answer is Invokana, out of all the SGLT2 inhibitors in Canada. So I think I'll stop the presentation there. The next presentation, I believe, is April 8th, and I'll have it recorded and put up for you guys to view. Again, if you have any questions, feel free to email me at cdestudycourse@gmail.com or just check out my website. Thanks for your attention today.